Eyal, we are very happy having you here. It's a pleasure, it's an honor. And thank you so much for making the time on your trip to Charité. And the stage is yours, and we're all curious to hear about all the recent developments in digital technologies in Israel. Thank you so much for coming. Vielen Dank.
Okay, so it's great to be here. Thank you for inviting me, Jens. It's really my pleasure. We know each other for many years, and I was looking for an opportunity to come and visit you, and I think this is a perfect opportunity. Thank you for coming this evening, and thank you, Mayor, for making the time. And I think spending the day at Romed today and meeting some of the colleagues here, I can tell you that one thing for sure, we're all facing the same problems. It's not different. Everywhere I go, and I travel a lot, in many countries, same challenges. We'll talk about them in a few minutes. Some ways to solve the problems is trying to throw more money at the problems, right? That's where we typically go. We have a problem, the answer is we need more, right? More resources, more manpower, more money. But I'm going to share with you today how we think we need to approach many of these problems. There's a reason why we haven't been able to solve them so far. And it requires a fresh thinking into how we move forward. So I'm going to take you on a journey. The next 40 minutes is a journey of what we've been doing at Sheba Medical Center, what has been our approach, and the partners that are walking on the same journey with us to try and redesign or transform healthcare as we see it. Of course, I cannot start without saying a few words about Sheba Medical Center, where I'm coming from. A couple of numbers that you can see here. Sheba Medical Center is the largest healthcare center in Israel, also largest in the Middle East. It's very large by many standards. You can see here about 2,000 beds, 10,000 healthcare professionals. You see some more of the numbers here. 12,000 babies delivered every year. That's a lot of babies. So quite a place. We have actually 7 hospitals on one campus: acute care, rehabilitation, children's, women's, heart, cancer, and Sheba Beyond, which is our virtual hospital, a hospital that delivers only virtual services. Thank you. Sheba is quite unique in one other thing. This is Sheba. It's all on one place. Okay? There's nothing outside of the campus. Everything at Sheba is in one campus. You see how large. We even have a lake. You can see up there. In Israel, having a lake is very rare. So it's not really a lake, but we like to call it a lake. It's actually a water reservoir. We collect the rainwater and we use it to irrigate. So, but it's it's nice. 25,000 cars come in every day into Sheba, and between 40 to 50,000 people come in every day to Sheba. This is the scope of the operations that we have to manage, so it's quite an operation. And this is not a very recent photo because there's been a lot of development over the last couple of years. Around Sheba, you see there's a lot of empty space. We're now building the city of health around Sheba. I mentioned this morning. 35,000 new apartments being built within a radius of 1 kilometer around Sheba. And 170,000 people that will move in around Sheba. We're expecting a lot of traffic problems, of course. That's one of the problems. And a lot of industry that will come in, especially high-tech industry, biotech, health tech industry that would set up shop around the campus to work in one place that would be devoted to healthcare. Everything devoted to healthcare. It's a 10-year plan. I won't talk too much about it today, but just to mention it very briefly. One of the things that came out of Sheba over the last few years is an initiative we call FOH. FOH stands for Future of Health. In 2018, we decided that we need to have a clearer view of where we're going. What is the future going to look like? Because when you ask different people, everybody has a different view, especially if you bring in different stakeholders. Not just different doctors, but imagine asking pharma companies where they think the future goes, or medical device companies, or politicians, or payers, or providers, or patients. Everybody has a different view of what the future of healthcare looks like. And so before you start any transformation efforts, any redesign efforts, you have to have a clearer view of the future. It's step number one. We all have to agree, or at least agree to something, on what the future of health would look like, because then it makes it easier for us to reach that goal. If we each move in a different direction, obviously, it'll take us much longer to get there, if ever. So we put together this community of healthcare leaders from around the world, about 50 organizations from 15 different countries that come together both virtually and physically. We started in 2018. During COVID, we had to meet mostly virtually, of course, but we came back to meet physically. You see, this is from the last meeting in Jerusalem 3 months ago, in November. And we're talking about what the future of health would look like. We try to reach consensus. We have research being done by Duke University in the US that follows all the meetings, tapes, transcribes, and then we use qualitative research methodologies to try and reach consensus and also understand where we lack consensus, because that's important as well. And then we publish this as papers on the New England Journal of Medicine Catalyst, which is one of the premier journals in the healthcare. We already came out with 3 publications, starting with Healthcare 2030, the coming transformation, to specifically talking about digital health transformation and designing the healthcare workforce of the future. What would the workforce of the future look like? So this is, of course, available for you to read. It's free online. It's coming from the discussions we're having in this community. So FOH, for us, is the initiative that is setting the vision of where we need to go. And I'll talk a little bit about that vision today, and I'll try to save more time to talk about how we actually need to get there. Okay, so these are the 2 issues we'll cover. Before we talk about the future of health, we need to agree on the challenges that we currently face. And when I said we all face the same challenges, it's 100% true. And you'll agree with all the 5 points that I have up here. One is patient safety and quality. Huge challenge. Very briefly, because that's something I can talk for an hour about. In 1991, for the first time, we measured how much harm we're doing to patients in the hospital. And when I say harm, I mean hospital-acquired infections, falls, medication errors, pressure ulcers. We all know these issues. But in 2023, a new publication that came out on the New England Journal of Medicine, but by my previous boss, David Bates in Boston, came to the conclusion that from 1991 to 2023, we've made 0 progress in harm to patients. So for 30 plus years, we know about this problem. We have not been able to solve it. So should we try harder? Should we put in more money? Is that the problem? Maybe we need to think about this differently, okay? Number 2, we are not providing care that is focused enough on our patients, okay? We need to provide patient-centered care. Sometimes we get confused and we provide provider-centered care, okay? We're more focused on us rather than on our patients. It's a journey. We're transitioning, right? The world is changing. The patients today are not the patients of 50 years ago, and they will be very different than the patients 50 years from now. So they need the information. They need to be able to make their own decisions. They want to be a part of the decision-making process. And so on and so on. We're moving in that direction. There's still a lot more to be done. Number 3, equitable access to healthcare services. We have huge gaps in healthcare equity, in some countries more than others. But I will tell you, for example, we work in the US, in the city of Chicago, The average lifespan for a person living in South Chicago is 60 years old. The average lifespan on a person living in northern parts of Chicago is 83. 23-year difference within the same city in maybe the most developed country in the world. We also work in Australia. In Australia, every 10 kilometers you are moving away from Melbourne, you lose one life on average. Every 10 kilometers, you lose one year. 100 kilometers, 10 years less. Okay? This is unacceptable. We have not been able to solve this problem. Most advanced countries in the world. Okay? And yes, some countries more than others, and we need to work on this. I'm not talking about the low-income countries. I'm talking high-income countries that haven't solved this problem. Economic sustainability. I'll show you something on the next slide, which is really the core of the problems. We are not able to sustain healthcare economically because healthcare is becoming more and more expensive. Why is it becoming more and more expensive? Because, one, we always find new solutions, new therapies that are more expensive, more advanced MRI machines, more expensive oncology drugs. We have drugs today that cost $30,000 a month to treat a patient and extend somebody's life 2 months. Who are we to say it's not worth the money? So it's a big question. We are at a point in time, and what I'm about to say I think is very significant, and please think about it later on. We're at a point in time where our grandchildren will receive level of care that is lower than what we are receiving today, because the healthcare system will not be able to sustain it. Imagine, we might be living in the peak of what healthcare services can provide. We never thought about that, right? We always thought the generations go, as they go forward in time, higher levels of care will be possible. But maybe this is the peak, okay? You'll see that in the next slide. So this is critical, and it's, again, all around the world. And workforce shortage and burnout, we talked a lot about that today. Not enough doctors, not enough nurses, not enough healthcare professionals. It's not a profession young people want to go into. I don't know if you can blame them or not, depends on which country, but it's a problem. And of course the burnout, especially during COVID. We have not been able to solve these issues yet. I was mentioning before, in the US, a hospital pays for a nurse, not the nurse herself, but the nursing agency, $300,000 a year per nurse. Okay? Going back to sustainability. It's not sustainable. To keep the patient-to-nurse ratio that the US is required by law, and so they can't escape it. That is why 10% of hospitals in the US have gone into bankruptcy in 2022. 600 hospitals have shut down their doors in 2022 because they went into bankruptcy. Because they have to pay $300,000 per nurse. So I think this next graph really significantly says why we need to change. I'm looking at the graph on the left here. You see the existing resources over the next 10 years. We'll have a little bit more resources with time. That's the lower graph. But then the required resources are going up much faster because of the things we've mentioned. More population, more elderly population, more chronic disease. I haven't even started talking about Alzheimer, which is a problem we're nowhere near solving. It's going to be much, much bigger 20 years from now, okay? Because we all grow older. Alzheimer is there. It's not going to be solved over the next 10 to 20 years. Major economic problem, as well as other problems, of course. So the gap between the existing to what is required to sustain the level of care we're providing today is going to grow. We will not be able to cover that gap. If we don't think differently about how we're designing healthcare, this gap will require us to lower services. This is exactly what I meant before. And on the right, this is the entire story. We want maximum outcomes, maximum human experience for the least resources. This is what we all need to strive for. This is where innovation and transformation efforts should focus. Okay, so describing everything. What are some of the trends? And I do want to focus a little bit about hospital care. We'll take hospitals, although, of course, the world is much bigger than hospitals. But let's focus, at least for the next 2-3 minutes, on hospitals. So what are the trends in hospital care? We know that one of the major problems we have in hospitals is that care is expensive. Why? Because hospitals treat the most severe patients. So we need the most expensive technology, right? The 7 Tesla's MRIs and the surgical robots and so on and so on. We know that care at the hospital is unsafe because I mentioned before we have not been able to change quality and patient safety or improve it over the last 30 years. So that means, and this is something already happening, whether we like it or not, that care will be pushed out from hospitals to the home. Okay? Otherwise, we will not be able to sustain this. So care will be pushed out. This is already happening all around the world. In the US, actually, if you look at numbers over the last 70 years in rate of hospitalization, this is per 1,000 1,000 population, it has gone down about 30%, from 900 to 633 days per 1,000 population. So we're already seeing a decrease of 30% in 70 years. That's quite a long time. We're expecting to see the same drop of 30% over the next decade. So this is accelerating tremendously. The industry has to account for it. I had a chat with the CEO of Baxter a couple of months ago, and I asked him, what are you guys doing? They're working with ARC. Baxter is a very large medical company that works specifically to design solutions for hospitals. I said, what are you guys doing to prepare yourself towards the fact that you're going to lose 30% of your market over the next 10 years? He said, we're doing nothing about that. Soon enough, a couple of months later, they opened a new unit to develop solutions for the home. So maybe we had an effect. So this is a trend already happening, but not everywhere. I went to Denmark, talking with a major hospital CEO. And he was tasked from the government to be in charge of 7 hospitals, decrease the 7 hospitals to 2 hospitals, but consolidate beds. So he told me, listen, we had 1,000 beds altogether, and during the consolidation, we went down to 800 beds. And he was very proud about that. This is what he was set out to do by the government. This is where we're heading. We're heading towards consolidation of hospitals and moving care from the hospitals to the home. And I'll share with you the model later on. Digital health innovation is going to help us achieve that. Okay, we'll see some examples later. Personalized medicine is going to help us achieve that, because think about it. If we're able to predict acute conditions like stroke and myocardial infarction, if we're able to predict and prevent it, we decrease the load on hospitals, because these acute conditions actually end up at the hospitals. That's a lot of the population we see at hospitals. So prediction, prevention, only when that fails we cure, and when that fails we rehab. We'll always need cure and rehab. We'll never be able to do without it. But the more we'll be able to push towards prediction and prevention, the more we'll take the load off the acute care and the hospitals. So that's going to help us get there as well. And we'll see hospitals of the future get to be smaller. We always will need hospitals. We don't think hospitals will disappear. We'll always need hospitals. But hospitals will become smaller with fewer real beds and more virtual beds. I'll talk about that later on, what is a virtual bed. And they will provide mostly intensive care, because we don't see intensive care going to the home, right? Complex surgery, which will always need to be at the hospital, and highly specialized services. So hospitals of the future will be smaller, but more specialized. Okay, this is where hospitals are heading. So this was a little bit of a zoom in on where hospitals of the future are going. We call it moving from a house for the sick to a city of health. What is the house for the sick? This photo is from Sheba. This is one of the original buildings built in the early 1940s by the American Army. Sheba was an American field hospital built in the 1940s that was never used. Never used. When the country of Israel was established in 1948, we had a brand new field hospital to use. So this is one of the original buildings. I know you have buildings going back even older than that.
Still in use.
And still in use. Yeah, they become storage, these buildings. But the Hebrew word for hospital is Bet Cholim. Bet Cholim is a home for the sick. That's the translation. Home for the sick. So this is the old version of hospitals as we see them, where we focus on acute conditions. We call it sometimes garage. You know what? It's like a garage. Your car is broken. You take your car to the garage. You come back in the afternoon. You pick it up. It's okay, right? That's the hospital. We bring the sick. We want to pick them up again when they're healthy. This is the approach we do at hospitals. We focus on illness rather than well-being. You know, if you're not sick, don't come knocking on our door. We're even agitated when somebody is healthy and comes looking for services at the hospital. Quality and patient safety, we said, is still not where we want it to be. We don't have the resources. We talked about that. It's going to grow worse and worse with time. We're still teaching people with the traditional apprentice model. You know, we say, see one, do one, teach one, right? You know this, right? This is how we train. This is the old way. This is how doctors and nurses were trained forever. And we are provider-focused rather than patient-focused, as I've mentioned before. Can give you a lot of examples. And of course, there's a big issue of staff burnout in the current hospitals. What is the transition we're looking to do into a city of health, where the focus is on well-being for the long run? We actually want to treat the healthy and prevent them from being sick. Clinical administrative data and analytics-based decision-making will make the hospital of the future much more effective and efficient. Maybe I'll give some examples if we have the time later on. Health without an address. The hospital will not have an address. It doesn't matter where the hospital physically is. When we have a saying, when people say, I'm treated at Sheba, you know, the old way of thinking is that you actually go to Sheba. Right? When you're treated at Rumed, you actually go to Rumed to get treatment. But in the future, you're saying, I'm treated at Sheba, but I have no clue where specifically you are treated, because Sheba is everywhere. Sheba is in the cloud, Sheba is at your home. It's everywhere, right? So there's no address or relevant address. Patient and family focused is where we need to move. Reducing staff burden. And we'll see new professions come around. I won't be able to talk about that today, but it's a big issue. Moving to competency-based education, where you're being educated until you reach a certain competency, and not for a set number of 7 years, because it was determined. And so on and so on. There's a lot of things that we can talk about. But this is the vision that FOH is setting out. Of course, there's a lot more, and you're welcome to read the 3 papers I mentioned. That goes into much more details. So I said I want to focus on how do we actually get there, okay? So now that we have a vision, how do we move from vision to reality? You'll agree with me, this is the bigger challenge. Setting the vision is sometimes even fun. You know, we get together, you saw we met in Jerusalem. It was actually, I didn't tell you, it was a spa hotel in the Jerusalem hills for 3 days. You could imagine we didn't suffer too much. So maybe setting the vision is even fun, right? But then the hard work starts, the real challenge starts. How do we, you know, the Americans say, how do we move the needle? How do we move this transformation from theory to action? So we need to do a couple of things. First of all, we think, and I'll talk more about it in a second, that you need to structure innovation processes. You have to have processes in place. We have processes for a lot of things. but we don't have processes to change. That's part of the reason why we're not changing. We don't have processes for innovation. That's part of the reason we're not innovating. We need to have those structures and build them into the foundations of our institutions. We have to build an innovation and implementation ecosystem. We have to work together. The challenge is too big for any one single organization. Even if we have 25,000 cars that come through our gates every day, we will not solve the problem alone. We have to work together. So we need to have an ecosystem of like-minded organizations that want to move in the same direction, that work to have a shared vision and then take the baby steps to make that vision a reality. We need to coordinate efforts, as I've said again, because if we each go in different directions, we'll never get there. We need to build evidence in healthcare. As you know, evidence is everything. Without building evidence, we will never be able to scale up. So evidence is a big part of what we need to do, and you'll see some examples. And we need to continuously revisit the vision, because it always changes. The perfect example is COVID. COVID changed everything for us. In 2019, we met at FOH. The meeting was in Montreal, November of 2019. Nobody imagined what's going to happen 3 months later. We were talking about changing the world, and then the world changed on us, right? 3 months later. So we need to continuously ask ourselves, what is the vision, and revisit it, because it's always in flux. And this is exactly why, in 2019, we launched ARC. ARC, in many ways, is what will make the vision of FOH come true. We'll talk in a second how we're intending to do that. This is a photo from the launch ceremony that we had in October of 2019, end of October, again, just before COVID. And you can imagine we worked for 3 years to build ARC, 2017, 18, and 19, to build it to a place where we could launch it and start creating that impact that you're going to see. And in many ways, FOH is the guiding light. It sets the vision, and ARC turns the vision into reality. To be able to do this on a global scale, not just at Sheba, on a global scale, we even set a date for ourselves. We mean to do this by the year 2030. I say to my team, the clock is ticking. We don't have that much time. 2019, 2030 seemed very far away. Now it's coming very rapidly. But this is the aim that we have. We've built a strategy that will allow us to get there. It's built on 4 fundamental principles. The first one is focusing on digital health as the main transformation vehicle that will make the most impact on healthcare over the next 10 to 20 years. We know this. Before COVID, I had to explain why digital health is so important. Today, I think we're all convinced, right? We don't need to convince anyone anymore. And we only need to look at banking to see what it did to banking over the last 10 to 20 years and how much banking has changed. You know, just to remind you, 20 years ago when we wanted to just check our bank account balance, we had to drive to the bank, find parking, stand in line, get to the end of the line, ask for the balance, get a little piece of paper printed to us. We were looking at the paper like this so nobody in line would see the balance, fold it nicely, put in the pocket and go back. Today, 3 clicks on our smartphone, we know the balance. Healthcare will be just the same. I predict that in 20 years from now, when you log on to receive a service to the website, healthcare services, and you're being told to go to the clinic or go to the hospital, you'll curse and say, what is this? I'm switching to another HMO, right? Just like we're saying today, if I log on to the bank website, and I want to do some transaction and I'm being told to go to the bank, you know, what kind of service is this? I have to sometimes take time off work, again, stand in traffic, etc., etc. So this is the same transition that will happen to healthcare over the next 10 to 20 years. I say to some people that, you know, healthcare 20 years from now will be unrecognizable to somebody from the present. We will not be able to recognize it. It will be completely different. And digital health will drive that transformation. So this is number 1, and I'll show you in a second I think I'll show you. I don't know if I have the slide. What we're focusing on when we say digital health. The second is open and organic innovation. You know, we talk a lot about in academic institutions, we talk a lot about organic innovation. This is innovation from within the institution. We try to create innovation from within to solve our problems by ourselves. You know, institutions invest a lot in internal innovation processes. This is great. You can, in some places, even make money from commercializing your own intellectual property. It's being done a lot in the US. Of course, in Sheba, we do this a lot. But it's not enough for transformation. If you want to achieve transformations, you need both organic innovation as well as open innovation. Open innovation meaning looking outside the walls of our institution for innovation from outside. Some of the things that we've seen here just this evening. Most organizations are not able to do that. Even if they do find, you know, we work with some institutions, some in the UK, NHS is pretty terrible in that. We work with institutions in the NHS. They have a nice technology they find in the outside, they're not able to bring it in. There's no mechanism to bring new technology to work with you. There are a lot of processes that make this a very, very lengthy process, and really they don't even know where to start. So we need to be able to scout outside, to find the right technology, to be able to bring it in, do a pilot if we want proof that it works. Sometimes it's critical, even though it was proven in other locations. And if the pilot works, do a large-scale implementation so that it can actually have an impact on our patient population and drive value. This process is something that very few institutions in the world can actually do. And this is what we need to build as part of the structured process that we need in every medical institution. The third is international collaborations. We have to work, as I've said before, with like-minded organizations all over the world. I start my days many times speaking with our partners in Australia. Because of the time difference, it's their end of day. I go on to speak with our partners in Europe. In 3 p.m., I speak with the East Coast in the US, and at 6 p.m., I speak with the West Coast in the US. So I have a long day. But then in the middle, if I have to speak with somebody from Sheba Medical Center, many times it's on Zoom as well. Because it saves me 20 minutes of going across campus. You've seen the campus. So technology allows us really to collaborate with anybody. So we need to find the best collaborators. This is where the world is moving. International collaborations. 100 years ago, we used to look for our collaborators across the street. Then we looked for collaborations in the same city. Then we moved to look for collaborations in the same country. But the world has become small. Let's look for the best collaborators and work with them. You'll see them in a minute. And finally, the last point here is something I've already mentioned, and this is the structured approach to innovation, structured processes. On the 3 years that it took us to build ARC, we looked back at all the successes and all the failures we had in innovation and transformation, and we wrote the ARC cookbook. And you know what a cookbook is, right? If I make a recipe at home, and each one of you makes a recipe from the same cookbook at your home, the dish would look very similar. Not identical, but similar. This is the idea of a cookbook. We can structure innovation processes and then implement them in different centers around the world to really fast-track innovation. And this is a lot of what we do. I won't have time to go into this today, but these are the 4 ARC concepts. Just to show you the ARC ecosystem, about 90 startup companies that are ARC members, each one with a proven technology that will help us transform the future of healthcare. Each technology here is critical in the way we see it. This is what drives us to choose a company, because we start with the FOH vision, and then what are the necessary tools to get us there? We look for the companies and bring them in. Everything is proven. Some of it is organic innovation. The upper part of the slide are innovations coming from within Sheba Medical Center based on our own intellectual property. The bottom part of the slide are leading companies from around the world, including some German companies, that we have brought in through open innovation platform. Again, open and organic. Then we have our accelerator with Boston Scientific, which has already spun out 12 companies, including 2 nice exits. And we have our own investment fund. I won't go into the investments, but also we invest in companies we really believe are transformational in their design. I'll show you in a minute the company you see here called ADOC. This is, you see the logo. We'll talk a little bit about this company in a few minutes. Corporate strategic partners at ARC. You know many of the names. These are large industry companies that work in ARC not to get access to our data, because they all want access to our data, but to co-innovate with us, to work together to create new solutions that the market requires. I'll give you one quick example, and we'll talk more about it very briefly later. Intel, one of the recent additions, you might know they're losing the battle on processors, and they want to move to diversify to a new business. They're looking into artificial intelligence end to end, from the processors to storage, computing power, GPUs, all the way to the analytics themselves. They are working with us as their only partner in the healthcare world to create new solutions. I'll show you in a second what solution we've built together with Intel. Hopefully we'll take it to the market as well. But these are the corporate strategic partners, and these are the medical institutions that are part of ARC. There's about 35 of them in many different countries. All continents are represented, including South America and South Africa. A big focus on the US. Jens, you mentioned a few names before, but also not a few from Europe as well. Denmark, we have 2 institutions, and the UK, Switzerland, Sweden, and of course Germany. We work very closely with all the partners you see here. We do co-innovation. We innovate solutions together. We implement solutions together. We try to solve challenges together. This is a core of what we do with our partners. We exchange data with many of our partners. You're on that path. You have an electronic medical record across your system now. The next thing you're going to ask yourself is, what do we do with the data we're starting to generate? We need to share the data between and turn data into value. You know, there's a saying, data is the new oil, but even oil can't do anything if it's sitting below the earth, right? You have to be able to make value out of the data, and this is something that is essential for the future. You'll see some examples. Once a year, all organizations at ARC get together every June at Tel Aviv. I invite you to come. It's called the ARC Summit. 800 people from all over the world. The hospitals send full delegations, not just one person, full delegations. The industry partners send full delegations. 800 people come for 2 days of huge amount of innovation, interactions, business-to-business transactions. It's really a big, big event, and of course we'll be very happy for you to come and join us on that huge celebration of innovation. Just to show you, this is the new ARC building we're now building. 20 floors, 115,000 square meters, 30% wet labs, 70% innovation space. We're not building it so big for our own team. We probably need just 1 floor, but we're building it so big because we want all of our partners to move in. We firmly believe that if we share the same rooftop, we're able to really drive collaborations to the next level. And so if you come in 2025, this would be ready. Before that, it's a big construction site. So how do we move from vision to transformation? I want to show you some examples of what is currently happening. I'll start with the artificial intelligence. You know, there's a lot of problems with artificial intelligence. When you'll talk with people and you'll hear discussions on, you know, why isn't artificial intelligence achieving what we are setting out for it to achieve? Why aren't we there yet? You'll hear a lot of problems. Some of this is related to the data itself. You know, the healthcare data is very fragmented, low quality. There's a lot of missing gaps in the data. It's unstructured. You cannot share data easily. There's a lot of regulations. So it's a big problem to create AI solutions when there's so many problems inherent in the data. But there's a big opportunity we can capitalize on right now. And we've been doing this for the last 8 years. And this is imaging and video. Images like CT scans or digital pathology are data. You know, the base of the imaging is data. But it's complete data. Nothing is missing. Unlike clinical data, clinical notes that are unstructured. This is structured data that we can start to work on today, yesterday. So this is where we need to push artificial intelligence and also video streams. I'll show you a little example from the three. The first one is ADOC. I mentioned the name before. ADOC is a company that came out of Sheba. In 2016, two data engineers, data scientists, left the Israeli army and decided they want to start a startup company in healthcare. What did these two guys do in the army? They were developing AI solutions for satellite images. Let's not go into the details why. You could imagine. But they want to move into healthcare. They came to Sheba and said, this is what we know how to do. What do you have for us? We said, sorry, we don't have any satellite images at Sheba, but CT scans as many as you'd like. And so in 2016, they started working on CT scans instead of satellite. And by 2018, they had a full product developed. We decided to focus on emergency medicine and look at emergency conditions in the ER. What typically happens is, a patient comes in, we do a CT scan either of the brain, the chest, looking for some emergency problem like stroke, cerebral hemorrhage, pulmonary emboli, abdominal hemorrhage. There could be multiple emergencies. But what happens typically is we take the CT scan, it goes into the radiologist, he has a full stack of CT scans he has to read. Of course, it goes to the bottom of the pack, and then it takes him about an hour or maybe hour and a half to get to that one sitting at the bottom. If it's a stroke, by the time we get there, it might be too late, right? And we all had these cases in the past. So what the AI does is in milliseconds, it reads the CT. It doesn't require an hour and a half. Even in the most busy shifts, it's only milliseconds. And when it identifies something, the only thing the AI does is bring up the CT on the list, on the queue, to the top of the queue. That's the only thing the AI does. It prioritizes which CT the radiologist needs to read first. There's no threat to the radiologist. I don't know if there's radiologists in the room, but we know that it's not easy to bring in artificial intelligence to read CT scans to radiologists because there's intimidation. It might replace us one day, okay? But this is not replacing. It's only setting the priority of the read. Just by setting priority, you'll see in a second what we accomplished. So in 2018, the company had a full product. They tested it at Sheba. We had nice results. They went on to conquer the world. Okay? Fast forward to 2022. By December of 2022, this technology is now integrated and implemented in 1,200 hospitals. 800 in the US and 400 outside of the US. You'll see the impact in a second. But from our perspective, this is the best example of global impact. When an idea that you have can create impact not only in your own institution, but have a huge impact on a worldwide level. So this is through ARC. That's what we do at ARC. We create evidence. Look at the evidence without going through the numbers. Reductions in length of stay. You see the numbers in different studies. Most of them were published for PE, pulmonary emboli, for intracranial hemorrhage, and other problems that we know. Quality improvement, you see some of the numbers here. Turnaround time reduction. We can be much more efficient with our time, which is a resource problem. You see the turnaround reduction from 22 to 55%, which is incredible. So all of this evidence was created in many of the ARC institutions that you see here to drive evidence, to drive more adoption of new technology. And this is from the latest trial that we did at Sheba to look at actual survival. You could see the improvement in survival. Mortality rates, all-cause mortality, has gone down from 27% to 17%. 10% reduction in 30-day mortality in these very severe cases that we can help with: hemorrhage, PE, and others. Now imagine how many patients we saved at Sheba with this technology. Now multiply that by 1,200. This is the impact that we need to create if we drive innovation in the right approach. Let's look at another example. I mentioned digital pathology. We've digitalized completely our pathology department at Sheba, but not just scanning, because many are scanning now the slides. There's actually no more microscopes. Everything is digitalized end-to-end, all the processes, and that allows us to introduce artificial intelligence into the workflow, and this is an example. So this is in lung cancer, and this was published just recently. In lung cancer, we look for mutations, right? We determine the therapy by the mutations. So typically what happens is we take a biopsy, we look under the microscope, we see that indeed this is lung cancer, and then we wait for a few weeks for the genetic sequencing to come back and tell us which mutation so we can start therapy. Now, we can see some things when we look at the slides. How did we interpret pathology slides throughout the history? I don't know, again, if there's a pathologist in the room, but the way we've done it traditionally, because microscopes have been around for many years, is we looked at the tissue and then we saw the outcome of the patient, and so we connected the morphology to the outcome, and we said this is a bad morphology, right? This is a bad outcome. This is how we wrote the textbook in pathology over the last 300 years. But the AI is much better than the human eye in being able to look at patterns. So the AI can actually diagnose the mutation based on the morphology. You don't need to send it to sequencing, which costs a lot of money. The same AI that tells you if there's cancer or not also tells you if there's a mutation and which mutation, just by the morphology. There's a lot that is happening on this. We've worked it into the workflows, and so today at Sheba, every slide goes through the AI to look for mutations. We still send it for full sequencing to get the result on the actual mutations, because we still need to be sure this is 100%. But with time, we'll stop doing that. We'll rely only on the AI and the pathology. This is a breakthrough. Where is this going next? Is this new unit we just opened last year called pathoradiomics. I've shown you through ADOC AI in radiology. Now you see AI in pathology. Let's connect the two together and have the AI determine the pathology based on the CT image. So in the future, we will not need to do a biopsy. We will only do a CT or a PET-CT or an MRI, whatever we will be working with, and we will determine the tissue through the imaging. So this is where the world is going. This is we're the first ones to connect the two together, but we're working with many of our partners in Mayo Clinic, Cedars-Sinai, Mount Sinai, and other locations to bring these two together. It's easy once you have the pathology figured out and the imaging figured out, now to bring them together. And we have enough images to do the large-scale analytics. This is another example of relating to precision medicine. We call it multi-omics. This is specific with inflammatory bowel disease. In inflammatory bowel disease, we know today it's a much more sophisticated disease than we figured out a couple of years ago. We know that there's genomics involved, the microbiome has an impact. There are a lot of factors that are important to understand how patients react and why do they react differently, why some respond to biologic therapy and others do not respond, why some respond better to steroids and some do not. We need to understand the full picture. It's not just the genetics. It's not just the pathology. It's looking at multi-omics, looking across the board. So let's look at a couple of omics. Ultrasound, MRI, colonoscopy is an omic, how we visualize the colon mucus. CTE, CT scans, of course. But then we also have video capsules. You know, we swallow video capsules, right? They take a full picture of our intestine. We get a 12-hour video, right, of the full intestine. Then somebody needs to look through the video. I'll give you a little hint. It's not a very interesting video. I don't think it's going to make it into Netflix. But when you look through a video like this and you're looking for ulcers or polyps, you might make a mistake, right? You could imagine the gastroenterologist looking at a video, somebody is coming into the door, he turns his head and oops, there was a polyp, right? Missed it. This is what we did with Intel. It took us 4 months to create an artificial intelligence program that in milliseconds reads through the full video. Our gastroenterologists today, when they sit down to look at the video today, have a report that says at minute 45 of the video, there's a polyp. Minute 65, there's an ulcer. I still go through the full video, but now I have the report in front of me. There's a much lesser chance I would miss something. Of course, this is just the beginning. We're starting to explore this. I think it will become a commercial product at some point, and we'll see it everywhere. But it makes perfect sense. We don't need very expensive gastroenterologists to look at videos. Okay? The world will be better if they spend more time with patients. So we look at the data coming from the AI on these videos. We have the patients wear Garmin watches. You see the watch over there? And we collect data on vital signs, on movement, on activity, how much they're active. There's a clear link between the disease activity and your overall activity, as we know. And we pick up symptoms and patient-reported outcomes through an app, as you see there. We take all of this data together, and then you can see where it gets us. So to understand and predict deterioration or severity of disease, there are certain measures we use today. One of them is called the Lewis score. The Lewis score accuracy is 0.67. 1 is the optimum. 1, it means it's 100% accurate. 0.67, this is something that gastroenterologists use all over the world, the Lewis score. You could add to the Lewis score fecal calprotectin, which is a protein we can find in the fecum, and that takes it up to 0.76. This is the best you can get. But using the multi-omics, only where we are now, already got us to 0.86, which is much superior to anything else that's being used, and it's just the beginning. We can definitely continue to work on it and improve it further. And of course, this was published and presented in all the major congresses. Telemedicine, moving from AI to telemedicine. We mentioned a little bit about that before. What is the opportunity with telemedicine? We have mobile health technology, and we have analytics. Let's start with the technology. The technology allows us today to do many things from afar that required, up until now, the patient to actually come to the care provider, just like in the bank. Okay? The technology allows us to do things now from our home at the bank without the need to go there. And technology in healthcare will allow us to do the same for our patients. One of them is a company called TytoCare, which allows doctors to examine patients from afar, whether it's 100 meters or 100 kilometers or 1,000 kilometers. We're able to examine patients, listen to the heart, listen to the lungs, look into the throat, look into the ear, and do physical examination. We can't do everything. There's a big issue still with doing abdominal examination. Still have to solve that. But at least some of the physical examination can be done from afar. We can do some lab tests. I don't know if you're familiar with this product. It's another company called Healthy.io. They signed 5 years ago a huge deal with the NHS. It's all around England right now. You do your urinalysis, your urine sample. You do urinalysis with the smartphone instead of going to some laboratory. You get in the mail this kit that you see here. There's a stick. There's an app you download. You take a photo of the stick after you dip it in the urine at home. Take a photo, and the image is being scanned. And using analytics, we know exactly what the urinalysis looks like. That is automatically sent to your primary care physician. So the primary care physician has it in his lab results. You don't need to send the patient anywhere. And you can even do ultrasound at home. And we talked a lot about today echocardiography. Okay, this is already happening. So on one hand, we have the technology. The other thing we have on the technology side is wearable technology. Many of us are already using it. We're going to see much more of it. If you look at the Small print, you'll see smart socks and smart pants and smart belt, smart ring. Smart rings we know, but there's a smart toilet outside. So everything is smart. And all a smart shirt. This is going to be the future. We're going to be collecting all this data through these smart devices on our body or at our home. That's not the problem. The problem is, what do we do with all this data? Because it's going to dump on us huge amounts of data we have no way to understand. Okay? And this is where we're going to need this last part, which is the analytics. Without the analytics, the data won't do us any good. So this is the roadmap we have to focus on as we move into the future. That allows us to move many of the things we do today in the hospital or in the clinic to the home, to the normal life, to the day-to-day. Exactly like we've done with banking, with the technology. So where is the telehealth revolution going to impact us? Primary prevention, hospital at home, chronic disease management, rehabilitation. These are the things that we can do. A lot of services, everything can be translated to remote care. Every service we have, if we sit down and think hard enough, we can translate. We just published a paper in the #1 journal in obstetrics and gynecology. Just today I got the notice on hybrid follow-up on high-risk pregnancy. Some of it is done at the clinic, most of it is done at home, but it's hybrid. We take the two together. So any service you can think about can be translated, okay? Let's see some examples. I mentioned that we do a lot of that at Sheba. In acute care, we have hospital at home program, which I'll show you in a second. We'll go very briefly, we don't have all the time. We have a strong program, hospital at home for psychiatry. I'll show you very briefly. We won't talk about chronic disease management. We have a program called MICA, which stands for Managed Integrated Continuous Care Application, where we take chronic disease and you'll see very briefly in a second, we break it up and turn it into a hybrid model where most of the care is being carried out outside of the walls of the hospital. We have a virtual diabetes type 1 clinic, and rehabilitation, tele-rehabilitation, and telecardiac rehabilitation, which is a very strong program we have. I won't have time to go into it today, but I'll just mention on cardiac rehabilitation, there's a big accessibility issue, I'm sure in Germany, I don't know the numbers, everywhere in the world. We know what are the indications to getting cardiac rehabilitation. In most countries, between 10 to 30% of eligible patients actually get cardiac rehabilitation because it requires inpatient, and we don't have enough beds for inpatient cardiac rehabilitation for everyone. So only up to 30% actually receive it. But if we are able to translate it to telecardiac rehabilitation, we can jump up from 30% to 70%. That's what we've done in Israel. That jump from 30 to 70 has a huge impact on the public health, on the average life expectancy. It's one of the biggest pushes that we've done in Israel over the last couple of years, is moving for cardiac rehabilitation at home through telemedicine means. I won't have the details today, but if anybody's interested, they can follow up later. Let's talk a little bit about the hybrid hospitals that I mentioned before. This is the traditional hospital. This is a photo from Sheba on a very busy winter day before COVID. Of course, COVID didn't do much good to this. We sometimes have patients in the hallways, right? We don't have enough rooms. Overflow, influenza, RSV, whatever we all are facing. We need to move to hybrid hospitals. Hybrid hospitals have both virtual beds and physical beds. So imagine a 36-bed unit that has 30 physical beds, metal beds, the way we know them today, and 6 virtual beds, which are at the patient's home, but they're the same acuity. These are patients that require hospitalization. The doctors at the department get to choose where they want the patient. If he's okay at home, we should have him at home. If he needs to be next to us, we would have him on a real bed. We have this model at Sheba. What we found is that if you start with 34 and 2, only 2 virtual beds, you quickly move to 30 and 6, and on that journey, who knows where we're going to end? Maybe 18, half virtual, half physical. The same doctors in the hospital care for those patients at home. They are responsible for them. They are most knowledgeable about this. They know how to treat these problems, right? It's not the doctors in the community that now know how to treat these problems that require hospitalization. But every day they do their morning rounds in front of a screen, examining the patients at home with TytoCare, for example, to listen to the heart and lungs, looking at results of labs and imaging, because if they need imaging, they order imaging, and the imaging comes to the home. Nurses come to the home at least once a day. We contract with nursing services. We don't send our own nurses, so we contract with nursing services, and we all work on the same electronic record. So whatever I write to the nurse, she sees on her side, and on the tablet, she goes to the home. And I can give you more examples of what we do to make this work. If we need a consult, think about it. Hospitals are perfectly positioned to do this. What do you do in the hospital when you need a nephrology consult on your patient in internal medicine? You fill out a form to ask for a nephrology consult, and the next day, maybe even the same day, you get the consult. What do you do if some community service needs nephrology consult? It's a big hassle, right? So if I order a consult for my patient at home, the same nephrologist in my hospital, who I used to see coming physically, would log from his office to see the patient at home and provide the consult on the same day. So hospitals already have the resources there. They're perfectly positioned to take accountability on those patients at home, to make the clinical decisions, which is what's important. There's economies of scale here. It costs less because the resources already exist. We've taken 36 beds, we're paid for 36. We didn't change anything. It's still 36 beds. So we don't need more resources even. This is where we need to push, to move. Not to have outside agencies care for patients at home, because they don't know how to do the job at the acuity level that we're used to seeing. You need technology solutions to be able to communicate with the patients, to be able to perform physical examination, to be able to monitor. And of course, there are a lot of solutions. I've talked about a couple of these that can be handled. One of the things is about, with open innovation, is finding the right solution that works. And being, in the ARC ecosystem, we share our experience, we know what works and what doesn't, and what kind of technology to use for which indication. Same model in psychiatry. We have a psychiatry hospital at Sheba as well. But look what happens to the patient in psychiatry. These are the most severe psychiatric patients. Patients hospitalized in psychiatric hospitals. This is severe depression, severe schizophrenia, and so on. They come to the hospital through the emergency room, the psychiatric emergency room. Once we realize they need hospitalization, they go into the ward for 24 hours. We evaluate them in those 24 hours to make sure that they're not a threat to themselves and they're not a threat to their environment. And if they're not a threat, then they can continue their hospitalization at home. Now, hospitalization for psychiatric patients typically is longer, as you know, 2-3 weeks easily, many times. They do this hospitalization at home. We have video consultations with the psychiatrists, psychologists, nurses. They take vital signs at home. We have an electronic pill box, so we know they're taking their pills. If they don't, we call them, we send a nurse over. After they're discharged from their own home, of course, they're discharged from hospitalization, then we take responsibility on these patients for a full year with the payer. This is why the HMOs in Israel love this. That's why they contracted with us. We said, listen, whatever happens in the next year after they're discharged is our responsibility. If they bounce back for readmission, don't pay us. We're in charge. On the first year we did this, we lost a lot of money. We had to learn. On the second year, we broke even. On the third year, we started making money. Now the HMOs are suspicious. You're getting paid too much. So this is working. It's working because you need to be able to take responsibility, to be able to communicate with the patient, to make sure he's taking the medications, and so on and so on. This program is running for more than 3 years now with a lot of data. And the guy you see here in the photo, that's the head of the program. He's a psychiatrist in our hospital. Dr. Asaf Kaspi is going around the world talking about this program. I mentioned Mika. I won't go into the details. This is an example for Parkinson. Any condition you can take. Okay, let's decide what is the clinical protocol. Let's decide what is the patient population. Let's decide what are the tech solutions we need. We have tech solutions for Parkinson to follow up and quantify the disease, so we know if the medication is working or not. There's, of course, patient-reported outcomes as well, but on top of that, we have sensors that can measure the amount of tremor, and easy, right? We can measure amount of tremor. That data gets brought back into the electronic record, so we know, when to add medications or change medications. So we need the technology, monitoring, who's the team that's caring for the patient, multidisciplinary team, and what are the outcomes we're following, both financial and clinical, of course. So this is our version of, we also call it virtual IPU because there's a lot of resemblance to integrated practice units, but we call it Mika, and this is what we're doing in about 12 different conditions. Very briefly, 2 conditions. This is pediatric population. One is type 1 diabetes mellitus. The reason I brought this here because to show you we're using virtual reality on children so that when they need to take glucose checks or have the insulin pump inserted, children are always frightened. There's a high level of anxiety. They don't really participate in this. We use virtual reality to distract them. And once we do this under virtual reality, there's a much higher acceptance. We published a paper that shows that using virtual reality on pediatric patients with type 1 diabetes reduces the hemoglobin A1C levels. I'm sure you never thought that virtual reality can reduce hemoglobin A1C. It's not in the protocols. But, this is some of what we're doing with our virtual clinic. Congenital heart disease, we have a very strong pediatric hospital with a lot of congenital heart disease. We have these very, very young, tiny babies with heart defects before operations. Sometimes they have to wait to mature a bit before we operate, and sometimes after operation. We use technology to monitor them, and we're able to know how they're doing, and maybe we can decide on the timing of the operation based on the monitoring we do at home for many of these small babies. It's another program. We actually have launched this program also with the Palestinian Authority, because we have many, if you come to visit, and you walk into Sheba's cardiac surgery pediatric department, 50% of our babies are Palestinians from the West Bank and Gaza. 50%, sometimes more than 50%. So many times we have to send them back if they're not ready for surgery. We continue to monitor them when they go, to the West Bank or Gaza, and we can call them when they're ready for surgery, when they gain enough weight and we see they're more ready for surgery. And we have other programs with the Palestinian Authority as well. And I think the last example, we talked a little bit about virtual reality. This is one of our focus areas as well. I want to show you 2 examples. One on the left is for navigation in surgery. We use augmented reality to help us navigate. It's been done, but this is something we have done. This is specifically in sacral neuromodulation. You have to implement a pacemaker, and the procedure on average takes about an hour to do. Much of it is because you have to find the exact spot. Using augmented reality reduces the time to 30 minutes. And the same is true for many other surgical procedures. If you can take down the time, be more accurate, reduce complications, of course that has a big impact on many factors. And we published this as well. And we have a lot of collaborations with our ARC partners. One of our ARC partners is Cincinnati's Children's Hospital, one of the best children's hospitals in the world. You see a program we piloted with them, which is now expanding, where we have intra-operative consultation with experts from around the world within the ARC network. So I'm in surgery, I see, I have the child's heart in my hand, And now I need consultation from somebody from another institution in the world, and I put on the augmented reality glasses, they put on the augmented reality glasses, and they see the same heart I see. They're across the ocean. But we can communicate and we can collaborate as if we're in the same room. So this is the ultimate level of collaboration, which actually gets to the bedside and where do we need it next, the most in real time. And we're now expanding this program for other places. Last slide, I'll conclude. There are a lot of challenges. We talked about them. I think we agree. I hope you agree. We all share them. They're not different. That's one reason why we need to work together. Hospitals will need to be the one who first change. We carry most of the problems. We're the most expensive. We have the most difficult patients, patient safety, all of the things I've mentioned. Transformation will be faster in some places, and you need to decide if you're in the place that the transformation will be faster, or are you a lagger and you wait for the others, and then you do this. We want to take a leadership position. I tell to my teams, we want to write the textbook. You know, in medicine we study from textbooks, Harrison in internal medicine, and Nelson and others. Let's write the next chapters of what healthcare would look like over the next 10 to 20 years. And global collaborations will allow us to do all of this. And finally, we need to take a proactive approach. We cannot wait. We have to take a proactive approach if we're to see these changes take shape earlier. And we need all the stakeholders at the table. It's not just about us providers, but it's about us working with industry, working with politicians, working with patients, working with all the stakeholders around the table, just like we do with FOH and what we try to do with ARC as well. So I think I'll end with this, and I don't know if there's time for questions, or I'll leave it to you. Thank you.